I have some announcements just to remind people about. This is a live presentation and it is being recorded. Mike's going to be pressing the record button. This allows for future participants who have purchased and are unable to attend to be able to view it at any time they want for their own reference. It's housed in a private YouTube channel, so it's very viewable by iPad and iPhone. And also the participants of this include the committee who made the continuing education and applied for CE, and the presenters have no disclosures, so that's important to mention. You will see in the corner, sort of to the right of your screen, there is the ability for you to be able to type in your questions. So please do that. Do that as we're going if you have a question immediately. Once the speaker is done talking, we have 3 speakers tonight. Once the speaker is done talking, we will address each question and we'll know, where it is in the point of the lecture. The other thing is while you're online, sometimes you may have a timeout in your screen. If that happens, just refresh your browser. When we're done with the meeting tonight, please make sure that you close your browser. It's really important to close your browser as it makes it difficult for us to record if all the people don't close out at the end. So that's really important. When this lecture is completed, you will all receive automatically a evaluation. Once the evaluation is completed and submitted, it brings you to obtain your certificate that you can print out. So all of that is sort of automated for you, which is a nice feature. Each speaker will also introduce themselves. So we will go ahead and begin now. Mike, we are currently recording, yes? Yes, okay. Okay, I'm going to go first. I'm Karen Marshall. I'm a nurse here at Northwestern Memorial Hospital in Chicago. I have been in actually the setting of the interventional oncology program manager for about 10.5 years. The physician I work with, well, there's multiple. There's 8 physicians that specialize in interventional oncology here, but specifically Dr. Riyad Salem and Dr. Robert Lewandowski are sort of the 2 main physicians that began the practice and started it here, and we've added on physicians since. And because of what we do, we are able to, think outside of the box, and that's kind of what this particular procedure is that I'm going to talk about today. We think outside of the box on its appropriateness in how to treat patients and tips with thrombectomy and what does that mean. I'll start that in just a second here. But that's what our doctors do. They basically think outside the box and we do the complicated cases. Now, Mike, I'm not seeing, oh, here it is. I see it now. How to advance the slide. Okay. So just going over normal anatomy, and I think everybody can see my cursor. So a TIPS is a portal systemic, it's a portal shunt, basically, transhepatic transcircular intrahepatic portal systemic shunt. Sorry about that. And what it does, it connects the hepatic vein to the portal vein. And the purpose of it is for patients in a normal liver, we have a natural flow where the portal vein brings in blood and the liver filters it, and then your hepatic vein takes the blood out so it can go back into the heart in order to get reoxygenated. But the liver itself has, when you have underlying cirrhosis from alcoholism or from hepatitis C, hepatitis B, it could be a NASH cirrhosis, it could be a cryptogenic cirrhosis, hemochromatosis. There's a lot of underlying liver diseases that causes a portal hypertension. And all that means is when the blood goes into the liver from the portal vein, it's doesn't go through freely to be filtered like they do for you and I. It sort of gets backed up a little bit because of the pressure inside the liver. So the point of having this stent is to allow this flow to go through very freely and allowing the blood to get back to the heart. So there we go. So here's an example. When we access the portal, the hepatic vein, we go in through the jugular down to the hepatic vein. We find all these different little collateral vessels that we can find in order to get into the portal vein. And the reason I'm showing a sample is I want you guys to see what a normal transjugular access through the capillaries into the portal vein, what it would normally look like. And so this is a normal tip. Everybody has seen this before, or hopefully you've seen this before. Once you're through, you're able to identify varices, like these big guys here. These varices cause patients to bleed, and we go in and we look for those and we coil those off so the patient doesn't have any problems with bleeding anymore. And then we leave behind a nice little stent. Here the stent is going, you can kind of see right here that the stent is sort of being deployed, and as the catheter gets pulled out, the stent starts to open, and then once the stent opens, we deploy a balloon. Hang on, I know we deploy this balloon here, and then everything sort of goes through very nicely out, and here's the coils from when we coil embolize the varices. Then we have a nice, the stent is fully deployed, it's nice and open, nice and patent, and you have a good post-run. So this is what it looked like beforehand, where you have a nice portal opening, and now the stent is placed and everything looks fine. Now, when you look at a patient who has this problem with thrombus, what happens is this nice open portal vein is either diminutive, meaning it's super small, but this is a normal one. I want to show you what a normal one looks like first. So this is a normal portal vein here, and this portal vein is nice and big. But the problem with some of the cases that we see is they really just don't have that. This one has a lot of little collaterals inside here, and here on the axial view, and then on the coronal view, you can't even see. It should be right there, and it's not. It's just completely diminutive. There are a bunch of just little feeders. The other thing to point out is the size of the spleen in comparison. Just really quick to look back, when you look at this spleen, it's, well, it's also big too, but this spleen is very, very long, so that's another indicator for portal hypertension. Same with this. Look at how big this person is. You shouldn't see this kind of a body cavity in the spleen. It's just not normal. But anyway, so to access this, it's really important that we're able to open this up again, because when you go to have a transplant, a lot of surgeons will turn down a patient like this for transplantation because they have nothing to connect to the portal vein to. If they don't have anything to connect to, they can't do the surgery. So our physician has been able to can't come up with a new solution for this problem. So I'm trying to look for a tool that's better. I don't like that tool. Oh, here we go. Here's your pointer. Okay, so what our physician does is we percutaneously stick the liver. We use an ultrasound. It's like doing a biopsy, but you percutaneously stick the liver, and just before the absent portal vein, you stick directly inside the liver into the portal vein to see what you can do here. So it's a direct arterial puncture, direct venous puncture into the portal vein, just proximal to where this clot sort of is forming. As you can see here, it's you can see a nice little all the little veins now that are inside, because this needle and this catheter is just inside. So that's perfect. So we just stuck that, and we let the catheter go through that. So we let the catheter go through, and get the wire in, so we can get past that into what we see just distal beyond the minimization or the occlusion. So here's just a nice, oops, there we go. So here's just a nice little pathway for this catheter and guide wire to be through the actual obstruction itself, or the diminutive portal vein that is there. But remember, this is just an arterial puncture, or a venous puncture through the skin into this vessel. So how do you connect it up to get the stent to go up? Well, this is where we're going to show you how this goes. So we're this is one showing you, my laser. This is one showing you what I just showed you, and these are the varices. All these are varices, very large varices for this patient. This patient had a really bad GI bleed, so we're trying to solve two things at once, trying to coil embolize these, and at the same time trying to put the stent in. So I just wanted to make sure you saw her varices. This is a nice little female. So then, now we're going through our normal transjugular approach, where we're bringing this through from the transjugular down into the hepatic vein. But now, how do you connect this portal vein catheter to the hepatic vein catheter? That's the trick. This is what he invented. Dr. Salem does this. So a snare is brought through this catheter, and when that snare is brought through, it's got to connect with this. The portal vein, the hepatic vein puncture. So once this is through and they connect, the snare is going to grab from this access through the skin. It's going to snare the transjugular access, and it's going to snare it. And then what you end up doing right here is you push the wire through. You actually just push it through. So this wire is snared down into here, and it forces it. Actually kind of a neat technique. So here we go. There it is, and it's sitting in those varices. I like this pointer. So it's sitting in this varices now. So now you have from the hepatic vein down into the portal vein, but you still have your access here percutaneously. I'll show you how that's solved. Oops. Okay. So while we're here, we go ahead and angioplasty or plasty open our access, and now we can visualize the varices very nicely, but we have a very nice open. When you saw how diminutive it used to be, you can see how nice and open this tip is now. And then we deploy, of course, the stent, and you can see here, and this isn't hopefully not too bad of a video, but right here is the stent. And then what happens with that percutaneous approach here into the liver is we coil it on the way out so the patient doesn't have any complications. And mind you, this is just the track from the liver to just under the skin. So that's this one. Then I wanted to show you what Dr. Salem, this is the completion run. I wanted you to see the actual completion run, how pretty the stent is in place, and the coils. So now we have that procedure alone took Dr. Salem, when he first started it, probably about 5 hours to do, 4 hours to do. So then he started to think, well, now what can I do? How can I make this a little better, make it a little easier? So he actually came up with what we call a spleen approach. So this is even funner, if that's such a word. So I want to show you again another example of a liver with a diminutive and non-existent portal vein here. And then I want to also show you this spleen. The spleen, and here's the splenic vein. So the splenic vein drains, and when it drains, and I'm sorry I can't show you that many slides because my talk was already pretty long, but when you see slide per slide, you can track the splenic vein goes directly into the portal vein as you sort of navigate throughout. So Dr. Salem's idea was to percutaneously get access through the spleen and get access through the liver and still get access through the jugular. So you'll see how this one is done. So here he is. Let me get this pointer. So here he is. This particular wire is coming right through the spleen. He percutaneously stuck the spleen and got into the vein and brought the wire and did a venogram here. You can see that we have in place up here, this is the transjugular catheter there. Did I do 2 or 1? Okay. And then when you have this access, we do a run and look at all these varices, lots of varices. They cause horrible bleeding for patients. So they also get embolized. But here we go. We're trying to take our wire and bring it up to get into this diminutive portal vein. Very nice injection. You can see how small it is, and it's not, because it's so small, you don't get a really pretty tree like you normally would see. So that's why it's important to gain access. So here is the transjugular wedged in the liver through the hepatic vein. So we're just kind of getting set up here to do the right thing. Now we're at the approach here where you're taking the percutaneous needle through the hepatic parenchyma into the portal vein that's just proximal to where sort of the diminutive portal vein is. So we're sticking this directly because really what we're trying to do is get down here. You can see this is where the spleen catheter is, so we kind of have a long way to go. So that's what we're working on here at this point. So here he finally gets through. You can see the catheter, the wire is through, and he's advancing it. Here, this is still kind of our goal to get these two together. And there he goes. This is the snare that's being deployed through, because now what he's going to do, he's going to snare and grab a hold of the spleen wire and snare it through to pull it up. So this gets pulled up, and you can see it kind of in the catheter inside there. I hope that's not too small for everybody. So now you've got this connected this way. So now somehow you have to get up into to bring this all together. All you have at this point is the catheter and the wire going from the percutaneously stick outside the skin into the liver, into the portal vein, matching up to the portal vein here, but now you have to get it to the hepatic vein. And here, this is still them snaring, I'm sorry. This is still them snaring everything together. Oh, here it is. There, see there's the wire, and they're snaring. They're pulling it. And now it's successful. Now they've got this all connected here. So now here comes the snare. Now the snare is, this time the approach for this is snaring the actual transjugular access. So the snare comes through, up through the spleen, because you want to bring this through this way now. And they've snared it. He's got a hold of it. And now he's pulling it through. So now we've snared this to this, and now we're able to connect the two of those. So now that's technically stentable, which is what we do. These little dots are measurements on how long this needs to be and where it's placed. So this is our stent, so it's starting to be deployed. And there it is. We're starting to balloon it right here. Some more ballooning. You can see a nice stent in a nice position. And it's not that kinked too, which is really nice. Here we go, we're ballooning it. Ballooning it. There's kind of a nice completion run from that. So you have a nice post stent. Here's the stent. You still have your track. I wanted to point out that this is the track right here to where the puncture was into the portal vein from outside the liver. And then this is the track in the spleen. that, I don't know if everybody can see that. This is the tract in the spleen here that also needs to be coil embolized, and that's what you do to prevent bleeding. So this is what the coils look like in the spleen. On that side of the body, you can tell because you see the ribs on that side. So there's that, and then we still have, as you can see, this is access through. This is sort of the wire that's still through the stent on the other side. And then here you have your nice completion run. Beautiful deployed stent with the coils in the tract to the liver and the coils in the tract to the spleen. And you have a nice pretty C like it's supposed to be. And that's just another completion run. So that's kind of the end of that talk, and I knew that that would take about 20 minutes or so to complete that. So again, the reason we do this is these patients, we've done so many of these now. There's a paper that Dr. Salem has recently published on the data. A lot of surgeons sort of shy away from patients in this situation because they don't have anything to connect to. But now when you look at this, when we place these stents, we actually make sure that we place the stent above where the actual anastomosis would be when they go to put in the new liver. So the stent is above that. So when they go to reconnect, they have a good probably inch or so in order to sew to. Now a TIPS isn't really something that's removable. So, you know, it's something that's going to stay there until they get a new liver. And these patients, because they do get a lot of contrast during this type of a procedure, we don't technically coil embolize their varices at that time. They do come back for another trip. And the reason they do that is it's not just due to contrast, but it's also due to the fluoroscopy exposure for the radiation. We don't want radiation injury, radiation burn for a patient on the table for a long time. So we bring them back after 30 days. We do a TIPS check, nice traditional TIPS check, and at that time is when we're embolizing the varices. And then the normal protocol thereafter is every 3 months they get an ultrasound to verify, you know, that their TIPS is still open. And then they go on to transplantation, and we have a lot of data to show that the transplant was very successful in patients that it wouldn't have been successful before. Do I have any questions? Are there any questions? Mike, I don't see any on my end. Do you see any on mine?
I don't see any, but if you guys do have questions, either later in the evening, that's fine. Just ask those questions. We can always come back to it.
Sure. So next, do you want Brenda to go?
I think I'll go ahead and go next, just so that I can go ahead and troubleshoot at the end.
Okay, Mike, introduce.
Hello, everybody. My name is Mike Wilson. Okay, yep, I'll go ahead and do that. Thank you, Karen. By the way, Karen, that was an excellent talk. Thank you so much for that. My name is Mike Wilson. I am the clinical director for Premier Radiology, Premier Vein Center, and the Borges Fibroid Center. I am actually from Kalamazoo, Michigan. Believe it or not, there is a place called Kalamazoo. Tonight, I'm going to be talking to you about radiofrequency ablation, and specifically metastatic sarcoma to the bone. And my talk will probably be about 20 minutes as well, so it's kind of short, but we'll go ahead and get started with that. I want you to know this is a challenging case talk, and the procedure, the situation that we're going to talk about here isn't challenging so much in a procedural sense. It's more challenging in the sense of a follow-up. So we'll kind of go through some of this stuff, and some of it will be kind of standard, and some of it will not. But this is going to be Jane Doe. And Jane is a 47-year-old lady, or was a 47-year-old lady who we saw a couple years back. She had a history of breast cancer that was diagnosed back in 2009. During some routine imaging, they had noticed a soft tissue sarcoma that was subsequently resected. At that time, the patient had some post-surgical fluid buildup in her abdomen, which required some additional imaging, and that led to the discovery of a sarcoma in her left iliac wing. We consulted the patient. They couldn't resect that sarcoma in her bone, so we consulted her for radiofrequency ablation. The patient, like I said, had a history of breast cancer. Nothing else, nothing else to speak of with respect to her past medical history. She was currently on no medications. She was allergic to a variety of things, mostly narcotic pain medications. But in terms of family history, the only history she had was a grandfather who had lung cancer. She had no breast cancer in her in her family. No mother, no sisters, nothing like that. She was a social drug user. She used marijuana, but social ETOH, nothing else. She was a married woman with several children. Her past surgical history consisted of a mastectomy, a resection of that retroperitoneal sarcoma. She had a cholecystectomy and a tonsillectomy. So when we saw her, she was actually doing quite well. She was a pleasant, well-appearing, cooperative lady. She was very well dressed, and in terms of her review of systems, it was all pretty normal, honestly. She did have a CAT scan, which we reviewed, and it did show about a 4-centimeter lesion. I'll show you the CAT scan in just a few minutes, but it showed a 4-centimeter lesion in her left iliac crest. The impression of the plan with respect to Jane Doe was she was a good candidate for RFA. Certainly, we talked to her about all the risks, all the benefits of the RFA, and we kind of answered all of her questions. So we planned for the RFA and scheduled it for about 2 weeks out. This should be her pre-procedural CAT scan, and if you look over, I think I can see if I can get the snappy laser pointer that Karen had earlier. So here's the lesion here in her left iliac wing. Okay, so it was about a 4-centimeter lesion there. We noted no other pathology in her pelvis or in her abdomen. And we'll go on to the next slide. And then this is just her procedural CTs. You can see a nice access, nice percutaneous access here with the needle right into that lesion there. It's kind of a cool picture. I wish you could see it in bigger, but I wish I had actually the series, because the series is awesome. You can actually see the tines, but couldn't include all of those. So let's see here. So basically, she had a CT-guided left iliac wing radiofrequency ablation. It was done, in your standard sterile technique. It was done in our CAT scan department. Sterile technique, the whole thing. So you can see here by the report that it was a successful radiofrequency ablation with adequate placement of the tines throughout the lytic bone lesion and associated soft tissues. This is her follow-up. This is her follow-up imaging. We follow our patients up. We usually will talk to them in the first week after their procedure just to kind of check in on them, make sure that they're doing okay. Then we'll follow them up again at 1 month in the clinic. We'll do repeat imaging usually at 3 months, and then again we'll see them maybe at a year. This lady was a little bit different in that she had some pretty major complications after her radiofrequency ablation. And I'll go through these with you and tell you sort of how this unfolded, and we'll get to the end result too. I guess I have a question here. Karen, I don't know if you want to. We're supposed to have questions, and so I threw up a question here, and maybe we'll be able to bring that up online.
I don't see the question. Oh, you mean I think it's the control room. I think it's the control room. Yeah. Yep.
So we'll go back to that.
We'll
go back to that image, and then Karen can throw the question up.
Is that it? Go. There you go. So we're going to do a quick.
So describing normal anatomy, where does the femoral nerve typically lie?
So please just click
You
on
guys
your
can vote on
answer,
this. You
and
don't have to.
then it will, yeah, you don't have to vote, but it'd be fun to vote. Oh, see, look at that.
Somebody got it right.
Uh-oh, but that's 3, 3, and 3. So 33%. So it's a tie at this point. Let's wait. 5, 4, 3, 2, 1.
All right.
It was,
So basically, the right answer was on top of the psoas muscle. So kind of right where that green arrow is. That's the normal anatomy for the femoral nerve. In Jane, the femoral nerve was over, let me see. The femoral nerve was over here.
oh, wow.
So let's go back here to her follow-up. So basically, when I talked to her that next week, within that first week, she actually called me, honestly, and she was doing pretty well. You know, she was in some pain. She had some difficulty ambulating. She had some pretty significant numbness from her thigh to her knee. The pain was getting better, and she was able to get around, but you know, it was difficult for her because her leg was numb. She denied any other complaints, no fevers, no other problems. We decided to kind of watch things, and I asked her to call me if anything worsened or anything changed, but that we would follow her up again at 1 month. So we went on to talk probably 3 more times over the next week or two, and things just didn't seem to be getting better. In fact, if anything, they seemed to be getting a little bit worse. So we saw her a little bit early, not at 1 month, but more like 2.5 to 3 weeks after her procedure. And basically, she was pretty numb really throughout her entire leg from her hip, maybe to just below her knee. It was so bad that she couldn't bear weight without using a walker. She definitely was. She was a professor at a local university in town, so it was definitely impacting kind of her normal day-to-day activities and what she normally did. So of course, one of our doctors who, you know, did the procedure, we saw her in clinic, and we talked about maybe some physical therapy. We talked about, you know, some possibilities of getting an EMG and looking at some other things. So that's what we did. We put her on a regimen of physical therapy along with ordering an EMG. Talked to her probably, I don't know, 3 more times the following week or the following 2 weeks, and things continued to remain the same or even deteriorate slightly. So we talked to her referring physician, her referring oncologist, and talked about maybe a plan of moving the patient's care to a more major medical center that specializes in nerve dysfunctions. So we did that. We contacted a physician at the University of Michigan, which is about 2 hours from here. We talked to the patient, her husband, at length, and you know, explained to them what they were going to, you know, possibly undergo. It was a series of EMGs that lasted, you know, over a period of months. She was seeing a neurosurgeon. At about, let's see, so this was 3 months after, actually 4 months after her procedure. We kind of were following her all the way along and talking with the neurosurgeons in Ann Arbor. In November, she had what appeared to be, she was doing a lot better. She did have her third EMG at this point showed about a 20% improvement in her muscle response. So she was actually doing quite a bit better. They were going to kind of just watch her, and again, they were going to just kind of see where this nerve dysfunction went and how much it got better. So they did another one. Let's see. So they did another one in January, of 2010. So she had her procedure in July. She had her fourth EMG in January of 2010, and at that point, she was about 50% back. Like her muscle improvement and her nerve function was about 50% better. Okay, so we're about halfway there, and it was really interesting to me because to see the progression of where she was when we injured that nerve to where she was 6 months later, with some pretty marked improvement. So we were pretty hopeful at that point. She was pretty hopeful. She was getting around a lot better. In fact, she was she was able to bear some weight at this point. She was able to stand for some periods of time. But it was real interesting kind of how this went. So again, let's see where we are now. So again, she had over a 2-year period, she had several treatments, several PT treatments and multiple EMGs, and by 2 years out, the patient had nerve regeneration of nearly 80%. So it was pretty amazing, the recovery that she actually had. The patient, the gist of this whole thing was that the patient had definitely a median nerve dysfunction that was diagnosed by an EMG. It was a decrease in the duration of her action potential along with a reduction in the area and amplitude of that ratio of that action potential. So she definitely had some major sort of issues caused by the burning or the irritation of that nerve during her radiofrequency ablation. The good news, again, is that she was able to regenerate nearly 80% of that. At this point, at 2 years out, she was no longer walking with a walker. She had some pretty slight myopathic deficits, basically just a limp. She was back to work. She was back to teaching. She was back to, standing in front of her classroom for 4 hours of a day. You know what I mean? So while the procedure itself wasn't that challenging, getting her followed up and recovered was the challenging part of this case. So we did a follow-up imaging at 2 years after, and you can see that lesion is pretty much gone. So let's see here. So remember, she had that 4-centimeter lesion in this left iliac crest, and this is 2-year follow-up imaging that basically showed it was gone. So that's pretty much all I got. If you have any questions for me, I'd be happy to answer any of those.
So while we're waiting for potential questions, it's interesting. We had something relatively similar in our own hospital. I don't know how long ago, but it's been a little while. So I know exactly what you're talking about. It took a significant amount of time, and you can't always know that that's where you're going to be. Sometimes these nerves, as you're doing these percutaneous procedures, they're just not visible on ultrasound necessarily, and you don't
Right.
always know what you're getting into. So I don't. It's not negligence. It's just where it is.
Well, and like you said, Karen, it's the normal anatomy. I mean, if you look at it, the normal anatomy should have been from this specific case. The approach for this specific lesion was well away from what normal anatomy for the femoral nerve would have been. You know what I mean? It just was her congenital, abnormality that I mean, it was just a consequence of the procedure, a complication of the procedure that we couldn't have possibly avoided. So she was happy in the end. I mean, she did very, very well. So it was good.
Mike, is that you on in your kayak?
That is me in my kayak.
Is that the day you tipped over?
No, that was
Okay.
That was 2 weeks later though.
And I
Thanks,
actually
Karen.
made that up. So I don't
did
see any
tip over.
questions at this time. Am I missing something? Do you see questions for you or I at this point? No?
I don't. Nope.
Okay. So Brenda, here we go. Do your interventionalists conflict with the pain management clinic recommendation with the RFAs?
Oh, I'm sorry. Say that again.
So between your interventionalist and your pain clinic physicians, are there any sort of conflict with recommendations?
Are you talking to me,
I
Karen?
know here. Yeah, do you not hear the question?
I'm sorry. I didn't hear you. I can't hear you. You were breaking
Oh,
up.
sorry. So do your interventionalists conflict with
Yes.
the pain clinic physician's recommendations with the RFAs?
Not typically. I mean, all of our cases, all of our RFAs are done in conjunction with anesthesia at Borges. So um, all of our anesthesia colleagues are in on every case. With respect to things that happen afterwards, we pretty much manage all of those things. We don't send patients to the pain clinic unless it's something chronic that we can't isolate, and then of course it would go to them. But no, I mean we all play nice in the sandbox, and I think having anesthesia involved in RFAs, and we do that with some other things too, but specifically RFAs is nice because then you don't really have to, the interventional radiologist and pretty much really the procedural nurse doesn't really have to worry a lot about that kind of stuff. So it works out nicely.
It's interesting because the pain clinic, thanks, Crystal. Crystal was the one who asked the question, and she was born in Kalamazoo, just so you know.
Oh,
Clinic, yeah, the pain clinic here, what's interesting where the conflict, I think, comes, it's not so much a conflict as is a competition, and it's usually with ESIs, right? You have your neuro guys doing the ESI, and then you have pain clinic doing
yes.
about necessarily image guidance, and that, but we don't really see that with an RFA concern because they're sort of two separate modalities. You have your tumor that needs to actually have some sort of a treatment. The problem is what the interventionalist has to balance is it a weight bearing bone? If it's a weight bearing bone, it makes it more challenging to treat it with an RFA versus sending to the patient to like an external beam radiation with the potentiator for the competition. So you're either going to get external beam or you're going to get an RFA. External
Yes.
beam has not as much complex, as much risk for fracture as an RFA treatment does for tumor. But a bone you can also stick in cement, potentially, depending on its location. So it's not so much a competition with pain clinic as it is with XRT and micro setting. That's just kind of what my experience is. So Brenda, are you around? We have on November 13th, our next webinar is going to be presented by a nurse practitioner, Gail Egan. She's going to talk about building a better IR team, RNs, RTs, and mid-levels. Then on December 10th, we have Kathy Duncan, who is going to talk about managing patients, medical management of patients with anxiety, claustrophobia, and panic attacks. Okay, so hold on just a second. Now that we can hear Brenda. So Susan, our overheads are available as far as this is a recorded webinar, and since you have paid for this webinar for the next 2 years, you are able to access this at any time. So hopefully that answers your question. Brenda, please introduce yourself and go ahead and begin your lecture.
So I don't know if you heard me at all. So I'm Brenda Boone, the advanced practice nurse for imaging services at Scripps Hospital in La Jolla, California. We're going to change gears to neuroprevention stroke care. And I know I only have about 10 minutes, so I hate to talk fast, but I can get through this. So I don't want to shut out anything. So I have 3 case studies, both one ischemic and 2 hemorrhagic stroke interventions that we've done. So strokes are typically 80% are ischemic and 20% are hemorrhagic. And they're a higher mortality rate for the hemorrhagic strokes, as you guys are aware, mostly from the subarachnoid hemorrhage is the most highest mortality rate. So the NIH stroke scale, most people are familiar with that, so I just wanted to give you an example of that. So most places are a primary stroke center. We are a comprehensive stroke center, and we go beyond just IVTPA, and we call it neurointerventional surgery. So typically that's a decision point between the patient, the family, and the neurologist, and also the neurointerventional surgeon when a patient gets admitted with stroke symptoms. We all know the gold standard is IVTPA, but there is value to intra-arterial TPA and mechanical embolectomy for those rescuing those patients that have either failed IVTPA, they're outside the IVTPA window, or have other contraindications. If the patient has a small vessel clot, typically mechanical embolectomy is not amenable to that, or if they have multiple clots, then intra-arterial TPA is really beneficial for those patients. And mechanical embolectomy actually is considered for those large vessel occlusions. So this is kind of our decision trees. Patient presents with stroke symptoms. They get a non-contrast CT. If there is a bleed, either subarachnoid hemorrhage or an intracranial hemorrhage, then we have neurosurgeons get involved. Typically a subarachnoid hemorrhage is an aneurysm or an AVM. So neurosurgeons could do aneurysm clippings or ventriculostomy. Interventional surgeons, or the neurointerventionals, do the aneurysm coiling. If there's no bleed and the onset is less than 4.5 hours, then we consider IVTPA for those patients as long as they have no contraindications. Best is small vessel occlusions, and large vessel occlusions really are best for neurointervention. If the patient presents at greater than 4.5 hours and less than 8 hours, that's when they call us. Typically, obviously, they're outside the window for IVTPA. So thrombectomy intervention has really changed over the last 10 years. So the Mercy Retriever was the initial device that came out. With the coil retriever, actually you put a little coil right through the clot and just pulled the clot out. The Penumbra device came out in about 2007. That was a suction-type device. And then the new generations both came out in 2012, the Trevo and the Solitaire, and they are stent retrievers. The advantage with the stent retrievers is that they radially move the clot to the outside of the vessel or the lumen, and then you start reperfusing it immediately. And then the stent, when it's removed, acts like a rake and takes out the clot when you remove the stent, and then they don't have to be on antiplatelet therapy. So my first case study is an 81-year-old female. She's shopping at Nordstrom's. That is a kind of a high-end department store here. Apparently she goes there fairly frequently. The staff knew her well. She had a sudden onset of difficulty speaking and weakness of her right arm right after she bought her purchases and was just going to walk to her car. The staff stopped her and called 911. She came to us, so we were about 5 minutes away from the hospitals where the store is. Her initial NIH was 10. She had a non-con CT at 1309, and then a CT angio of the head and neck, and then normal blood sugar. This is her initial non-con CT. Showed no bleed, so we went ahead right to a CTA, and that shows a, right in that circle there, an occluded left MCA. So she was within, obviously, the TPA window. She got her TPA started within 45 minutes. Joint Commission likes to see it within 60. We are well within that. She was on narcotine to keep her blood pressure down. But during her TPA infusion, she started bleeding in the mouth. Actually, her TPA seemed to not be helping. So we stopped the infusion. She had a repeat CT just to make sure she didn't have a bleed now, and then they consulted a neurointerventionalist. She, within 2 hours, is now in the OR for her neurointervention. This was her initial angio. Where that arrow was where her occluded left MCA. You could see they thought it was at least a 12 millimeter clot, and so you can see why the IVTPA did not work for her. So put a wire through the clot. You can see the distal end of the wire right about there, and put in the you can see distal flow. Put a Trevo device in. You can see where that's a stent right through the clot itself. opened that right up, and she had distal flow again. She was out of the hospital in 51 hours with no deficit at all. So I'm going to quickly go through. She was in the hospital just 52 hours. I'm going to get through these pretty quickly. I do want to show you two other case studies. So hemorrhagic strokes or aneurysms are typically either ruptured or unruptured. So ruptured strokes, usually you're looking at medical therapy and coiling, stent-assisted coiling or embolization with a pipeline device. So next patient was a 63-year-old man who developed a headache on a Saturday. Came in and was a headache. He's not had such a severe headache before. Had a CAT scan without any signs of hemorrhage at that point. He was on Eliquis, so they couldn't do a lumbar puncture at that time. He was discharged because his headache get better, but he had headache and nausea vomiting for 2 more days. He developed seizure activity on a Monday, was admitted then with an extensive subarachnoid hemorrhage. This is his initial CT, and he was obtunded. So he had a 10% chance of survival with an intervention. He got both a neurosurgeon and a neurointervention. So he ended up with actually 2 ventriculostomies because one of them clotted off. He was taken to the neuro suite. He had framing coils and expanding coils. Because his aneurysm was so big, the framing coils kind of help that open area that the blood is leaving from, and then the expanding coils to fill up the space. The aneurysm was filled, the bleeding stopped, went to the ICU, but he did die 2 days later. His hemorrhage was massive. This is this 3D image of his, let me show you so you can see that. This was his aneurysm on 3D, but this is where the aneurysm was leaking. So, and my last case was a 63-year-old female who had a sudden onset of a thunderclap headache, which really is what grabs your attention like a clap of thunder. Sudden, severe headache. It peaks within a minute and fades about after an hour. They're very uncommon, but you need to have them looked at pretty quickly. She had an initial angiogram, showed a aneurysm with an unusual takeoff. I will show you that in a minute. The neurosurgeon and neurointerventionalist decided with the patient to have a coiling procedure. So she had an initial diagnostic angio, and they came back for the intervention. So she was an unruptured aneurysm. She came in the morning, did a stent-assisted coiling. She had 15 coils placed, and she went home the very next day, did really well. She had a very unusual aneurysm. It looked like a, let's see if I can show you, like a little C takeoff on from the vessel. And this is a 3D image of that takeoff with so she had a really wide neck with a wide neck aneurysm, which is always difficult. So they use stent assisting for those wide neck aneurysms. So on this one, where the red arrows are, those are the edges of the stent. So we put a stent in first, so that when we place coils in the aneurysm, the coils don't come back out of the aneurysm. So those little markers are where the edges of the stent are. And we packed one end of it, kind of a horn. I guess it looked like a little double horn. So they did one side and then the other. So this is her fully packed aneurysm with coils. And then the final result with the contrast, you can't see the aneurysm anymore. So she did great, went home the next day. She had her 1-year follow-up with no issues at all. She's done fabulous. So I know I talked really fast, and I apologize about that, but did you have any questions for me?
That was excellent, Brenda.
It really was.
That was excellent.
So there's no questions coming through. So if you guys do have further questions, if we do miss your questions this evening, please feel free to, when you receive your evaluations, there's all the Erin contact information is on there, and they will pass along your questions to the 3 of us. We'd be happy to entertain that. And remember that this is viewable in the future via the recorded system through a private YouTube. Brandy does have a question for you, Brenda. Is there an age cutoff for the TPA?
Can you hear me? No, it used to be like 85, 90, but there really isn't any age cutoff anymore in TPA. As long as they don't have any other problems, there's not really an age cutoff, which is pretty amazing.
Yeah,
so
as
we've
long as
given
we meet all the
right. When the study first came out, there was an upper age limit. I think it was in the low 80s, but since then, there really isn't much of an age cutoff.
So Brenda, do you see in practice? Do you see a lot of people? Do you see a lot of people using intra-arterial TPA infusions?
Not much anymore.
No.
Once those stent retrievers came out, that was a game changer.
Yeah.
Although we're pretty frustrated that IMS3 trial came out and was presented at the International Stroke Conference last year, and that showed that there was an equivalence to TPA versus intervention. And so people were saying, well, you don't need to do intervention, but that IMS3 trial came from the initial devices, so they didn't use stent retrievers. That's really been a game changer. We're getting flow so quickly. Our outcomes are amazing.
That's awesome.
We're actually looking to get our outcomes published. So I'm working on an IRB application this week, actually.
Very cool.
That's fun. That's fun. So just some ending comments. Remember that at the end of this a webinar, an evaluation will be sent to you, a little link. You'll go ahead and move forward with that, and once you've completed the evaluation, you'll be sent to your certificate so you can print it. If you have issues with that, feel free to call the national office. They will certainly help guide you through that. Remember, we are always available for additional questions. And just to recap, coming up November 13th, we're going to be hearing about IVC filter practice development. Look for that email. Save the date. And on December 10th, we're going to be talking about managing claustrophobic anxiety panic attack patients. So we look forward to seeing you guys there too. Mark that in your calendar. Everybody have a great evening, and we appreciate your patience as we work through our technical difficulties. Everybody have a good night.
Thanks, everybody.